got that cherry bomb.
Welcome to Breaking Beauty Podcast, Dr. Ellis. I'm really excited to have you on the show because I'm a big fan of Prequel. I've talked about it on the show before. And, you know, we connected on Zoom and I just thought we chatted about my face flare-ups and I just thought you're just a wealth of information. So today we're talking about the terms everyone needs to know before their next derm appointment. So number one, earlier this year, Kylie Jenner was photographed at the couture shows in Paris with visible filler under her eyes.
Allegedly.
Well, what appeared to be
exactly
visible filler under her eyes. What is this phenomenon called, and how can we avoid this happening to anyone who's had eye filler?
It's a good question. So what we were actually seeing there wasn't the filler itself, but was actually like fluid that had basically wasn't draining properly from her face, likely because it was blocked by the filler. So those are called Malar mounds, or it can be called Malar edema. If it gets really bad, it's called festoons. But it's essentially this buildup of fluid kind of in the mid-face or near the tear trough. And it's thought to be due to poor lymphatic drainage around the eye. And so when filler is placed, it can block these lymphatic channels, unfortunately. And so the way we really avoid this is making sure someone's a good candidate for filler. So a lot of times people see hollowness under their eyes or bags, and they think filler is the only option for that. But there's actually many different ways to address it. And I find that people have these poor outcomes or undesirable outcomes if filler is what's used instead of maybe other things, whether that's surgical or other skin tightening things.
Okay.
Okay.
So should we ask anything before we go to the derm? Or like, what do you say? Am I a good candidate?
Yeah, usually people come in with a concern or they think, I want to get filler here, and they ask the dermatologist. And I think a good dermatologist, plastic surgeon, any cosmetic injector, they're not just yes people. They shouldn't just say yes because you want it. They really are supposed to be using their expertise to really determine if you are a good candidate and also review the risks. So even if you are a good candidate, this is still something that can happen. The nice thing about filler is that it is dissolvable. So these are not usually permanent changes that are caused. But nonetheless, it can be really distressing for people. And I think we all know that Kylie has probably had filler in her face over the course of many years. And sometimes that accumulation eventually can lead to that if not done judiciously.
Yeah. I feel like this is what's been in the air lately, and we've talked about it on our show, is there's more evidence that, filler sticks around on your face, that it migrates. And I think there are some people who are kind of moving away from it. And I know that some derms have they've actually said to me, like in real life, they're like, it's really about the practitioner. It's not about the filler.
Right.
And I'm curious what you think about that.
Yes, I completely agree. Like any tool when used improperly or in excess can cause a problem. And we do recognize that filler can last longer than we initially thought. It can move in the face. And I think it's really key is I think people used to rely on filler to do all the things that they wanted to improve with their face. They wanted contouring with it and they wanted volume replacement and they wanted it to lift and reposition tissues. And I think what people are recognizing now is that there's a myriad of cosmetic treatments that can be done ranging from non-invasive to surgical. And it's really about using them all in their very specific way to achieve the best outcomes and not just relying on filler to do all of the anti-aging things that you assume it could do. And so I think injectors are becoming a bit more conservative now that we have other tools, or I often collaborate with plastic surgeons because I think it's important to recognize as a dermatologist what my limitations are in the office in terms of what I can offer someone and be like, hey, if this is your desired outcome, we might need to involve surgery here. And if they don't want to do surgery, then just say, okay, then we're not going to do this either and not just do it because it's the easy thing to do.
Right. I love that.
Yeah.
And what about fat transfers? We're hearing about this all the time. What do you make of this idea as face filler?
Yeah. So
do you see people actually asking you for this?
Yes. So people will ask me for it. I don't personally do it in my office. I will refer someone to a plastic surgeon who has a lot of experience in fat transfer because it's actually a pretty tricky technique to execute well. And that's because fat is a living thing. And there's this unpredictability that goes with fat, which is that you could transfer fat, but maybe only 50% of it actually stays in the tissue. And so you really have to understand as a surgeon or the person performing that, you don't want to overdo it.
Yeah.
You don't want to underdo it and have someone be underwhelmed by their outcome. But I do like the idea of replacing fat in the face because that is something that can age us prematurely is to lose that volume. So conceptually, fat in the face is great and fat transfer can be done really well. I've seen amazing fat transfer. I've also seen people get fat transfers and feel like it did nothing for them because likely a lot of that fat that was placed there just didn't have any long-term viability. And so they lost sort of the benefits of that.
Right.
Yeah.
Right.
Yeah.
Okay, I want to ask you about Melomental folds.
Okay.
And where this is sort of coming from for me is one of my favorite pieces of content that you created is you talked about using Botox on the lower face, which I feel like gets a lot less attention than on the upper face.
Right.
I actually have come to be quite neutral about my eye wrinkles. I just think they're natural and they don't they're not unattractive to me. So they don't really bother me. But the drooping and the sagging, when it seems like it's creating a different emotion than I'm feeling is what I don't enjoy. So if like I look really sad because of my eyes and same thing with the mouth when it's drooping downward.
Yes.
So I'd like to hear again what Melomental folds is and how to do it correctly, not look like a Joker face.
Okay, so Melomental folds are essentially what we kind of colloquially call marionette lines. So it's the lines that go from the corners of your mouth down. And a lot of women start to notice them pretty early on. It's one of the first signs of aging. And it's really when you have descent of the cheek tissue and it creates this shadow. But there are other things like ligaments that exist here that, harshen that shadow essentially. And so you can use Botox there to soften the downward pulling corners of the mouth, but it has to be done very carefully because in the lower face, it's not just about how it looks, but there's a lot of functionality that you need to maintain around the mouth. You can't just paralyze everything because then someone can't talk or chew or kiss or eat or all the fun things you do with your mouth. Use
a straw.
Yeah, use a straw. And it can look weird too, as you mentioned, like that Joker mouth situation. And so Botox I like to use in something called the depressor anguli oris. It's a muscle that I would show you, except I can't do it because I have Botox. But it is a muscle that pulls down naturally on the corners of your mouth. In some people, it's a really strong muscle. In some people, it has barely any function at all. And so for my patients who, when I'm talking to them in our consultation, just at rest, they're kind of making a frown, and a lot of people do this very subconsciously. I know that they're likely to be that will likely be of benefit to them, but you have to place it so carefully, not only because you have to maintain the functionality there, but there's also overlapping muscles in the mouth that do other things with your smile and how your lower lip moves. And if you accidentally hit one of those other muscles, you're going to give someone an asymmetrical smile, or it's going to be hard for them to use a straw. And so it has to be done very, very precisely. I also think sometimes people get that Joker mouth because we were talking about filler earlier. Filler placed there can kind of camouflage a fold, and that's really all you should be doing with it. But if you try to overfill someone to get rid of all the lines and shadows there, they can just look like they're holding nuts in their mouth like a chipmunk or something like that. And I tell patients, like, you put enough product in somebody, I can get rid of any fold and shadow on your face. But really what the point of doing these interventions is so that you look better overall.
Yeah.
And so we need to look back and kind of look at the whole picture and say, okay, well, did what we do make a meaningful intervention in kind of the bigger picture of things?
Yeah. I think that's, most people, I would think that can only be addressed with filler, those deeper lines. So I think
I get both.
Yeah, I was gonna say,
it's
like, you
Botox
need both.
and the filler.
Yeah, and that's exactly what I think is, like, it has to be.
He's
dual
just jabbing. I'm letting him go.
Like, do your thing,
you're a
man.
derm.
We have to be working on multiple layers. We don't just age in our skin or in our fat or in our muscles. It's like it's a multi-layer process. And so if you're doing anti-aging in any part of the face, you need to be working in all the layers with all the tools you have available to you.
Yeah. I noticed you also mentioned that you inject with Botox to treat that, like, orange peel, or you called it cottage cheese. I call it orange peel.
Golf ball chin.
In the chin, which again,
golf ball chin.
I wouldn't.
Oh, wow.
Yeah.
I'm not trying to give anyone a complex here. Yeah.
No.
But that's accurate. I hear you.
But I do think, like, again, with texture, I think a lot of people would be thinking lasers, or again, they might be thinking fillers. So tell us about how the Botox helps with that. And is there a name for that?
So we
or
call
is it officially golf ball?
No, we call it peau d'orange. Anyone who speaks French will absolutely murder me for saying it that way. But it's basically that dimpling texture of the chin. And it's caused by the mentalis muscle, which is our chin muscle, and the skin overlying it. As we get older, our jawbone actually gets smaller. And so that chin muscle can actually become hyperactive to kind of like make up for our shrinking jaw. Yay, aging. And so that will start to tug on the chin skin. And over time, those cumulative movements, again, will lead to that more permanent dimpling of the skin. And so by putting a little bit of Botox there, you just soften things. And again, we're not trying to like paralyze the entire lower face so that it doesn't function, but just soften things. And people are starting to like not like the idea of Botox being preventative because a lot of people who are really young are doing Botox maybe unnecessarily. But in the lower face, I truly think Botox is preventative because once you have that permanent dimpling, it's very hard to treat, even with the most aggressive of lasers.
So I understand that we share a rosacea bond.
Yes. It's a deep one.
People know this word, but what exactly is it? And what are the telltale signs that you might have rosacea versus general redness?
Great. So rosacea is an inflammatory skin condition, and we don't have a full understanding of what causes it, but it can generally be characterized as redness, typically of the midface. So on the cheeks, the nose, the chin, sometimes between the eyebrows. And that can or cannot be accompanied by things like easy flushing, blushing, kind of that heat sensation overwhelming the skin. And then it also has a lot of pimples or pustules associated with it. And for so many people, they come into my office thinking they have adult acne and they really have rosacea going on.
Okay. And there are different categories or types, right? Because I don't flush easily, but I have the perma
red. Perma red.
The always on red. I have the perma red. So what type do I have versus?
So we actually used to categorize it, and now we're actually moving away from categorizing it, but I still feel like it's a really important thing for like contextualizing rosacea. So there's something called erythematotelangiectatic rosacea or ET rosacea, and that's really that central facial redness, and that can go with the flushing and blushing, but that's all considered one type. And then you have papulopustular rosacea, which generally still has that background redness, but then is more characterized by those little bumps. You can have the phymatous rosacea, which is the overgrowth of those tissues. And then you can have ocular rosacea. So a lot of people actually have eye involvement with rosacea, and they don't recognize that it's all part of this one thing. They think they just have like dry eye or easily irritated eyes, but they actually have a rosacea component. So I would say that you have erythematotelangiectatic dominant rosacea. And that's actually probably the hardest rosacea to deal with in terms of treatment. Sorry.
Oh, great. Oh, good. Okay. And so
well, you're on your way. You've got the azelaic acid going.
I do. I have the azelaic acid, echinacea,
Okay, great.
Which is by prescription. And so what should I lean into aside from that? And what should I take out of my routine at home? Like, can I ever use retinol again? Vitamin C really irritates me. Is there a good alternative for that?
Yeah, so I would say when people have rosacea, their triggers can be vast and varying. And when it comes to skincare, retinoids and vitamin C, particularly the like L-ascorbic acid form of vitamin C, can be particularly irritating. So usually if I have a patient with rosacea, we are kind of taking their skincare down to like the bare bones. So we're talking sunscreen, moisturizer, cleanser, nothing fun, just like the basics. And then in terms of topical interventions, it's usually prescription things. So we're looking at echinacea or azelaic acid, oftentimes metronidazole, which is an anti-inflammatory and an antimicrobial, as well as something called ivermectin. And I often will compound azelaic acid, metronidazole, ivermectin all into a single rosacea triple cream is what we call it, because that just makes it a lot easier than putting 3 things on. And so really the goal first is to get the rosacea under control and then start to try and add things back into the routine or like make the routine a little bit more exciting. But I always think like pick your goal. So the first goal is get the rosacea under control. Secondary goal is anti-aging. So you have to do one and then you can start tackling the other. I have plenty of rosacea patients, including myself, who use retinoid regularly in their routine, but they cannot tolerate that retinoid unless they are also on their rosacea medication. And so sometimes it's about picking your preferences in terms of what you want to be able to do and what your goals for your skincare ultimately are.
Right. I saw that you've recommended sulfur for rosacea as well, which I was like, wait, I've heard about that for acne, but how does it help with rosacea?
So it has similar properties of how we use, or like the things we like in sulfur for acne are why we like it for rosacea too. So it's antimicrobial. And with rosacea, there's this overgrowth of Demodex, which is a mite that lives on all of our faces. And some of us have this really lovely inflammatory reaction to it that contributes to rosacea.
I'm going to throw up.
I know. Like, it's really honestly kind of gross to think about. It's pretty gnarly. And we all have these things on our face, but people with rosacea tend to have more of them and just a bad reaction to them. But it's antimicrobial. It also helps clear out the pores. So if you are on that spectrum of papulopustular rosacea where you're getting more of like breakouts associated with it, sulfur can help with that. And it also helps with oil control. So some people with rosacea also have more of an oily skin type. And so sulfur is not my favorite for all types of rosacea, but it can be very beneficial. And so I will often prescribe a sulfur-based cleanser for my rosacea patients to see if adding that in can be beneficial. But there are also a lot of people out there with just red faces. And I know you asked earlier, well, like, how do you know if you just have a red face and not rosacea? And usually if you don't have any of the flushing, blushing component and no pimples, and it's just these like dilated or visible vessels on your face, that's more sun damage induced. And we do think sun damage is a trigger for rosacea as well, but I do think it's pretty prominent for sure. And a lot of patients come into me for other things, and I just happen to notice that they have rosacea, and they're like, oh yeah, like, I would characterize my skin as sensitive, like you mentioned, but they didn't know they had rosacea.
Yeah.
Right. Interesting.
I'm on the train to get the XLV laser done for the rosacea.
Love it.
Recco?
Yeah, totally. Absolutely.
I'm getting it done. Will my face be swollen? Because I have a bit of rosacea, but not official diagnosis. Like, but my mom has it and everything.
Yeah. So usually like XLV or V-beam are like the two most common lasers used for rosacea. One's not better than the other. It's more about like whose hand the laser is in. And it kind of depends on how much surface area they're covering. So if they're going after a few distinct spots, you probably won't be too swollen. But like when I treat my face, I am like a puffer fish for like 3 or 4 days. And like, but I've warned patients about that. And then they're like, Dr. Ellis, I don't know what you're talking about. I didn't have any swelling. And so I think it's just so variable.
There was a girl I follow on TikTok who did it, and she like couldn't drive home after because it was like swollen around her eyes.
So she had like immediate.
Yeah.
Oh, wow.
Mine's usually like at the 12-hour. Like I wake up the next day and my husband looks over. He's like, you did V-beam yesterday, didn't you?
Oh my God.
I'm fully prepared for the worst, but I don't care. I'm doing it.
Even if you treat just the cheeks, the eye tissue is so loose and sensitive to trauma that it'll just.
How many XLV laser treatments do you do? Do you do like a suite of them?
Yeah.
What do you do?
I would say on average, most patients need 2 to 3 in the beginning, depending on their level of redness, to kind of like kickstart things, because people with lasers, people are always like, just hit me hard, doctor. I was like, just go, and I just want to do this one time, and that's it. But lasers are so powerful that there's only so much intensity you can turn it up to before you risk injuring somebody and not getting any benefit. And so usually you need a series. I would say 3. I usually do 3, 4 to 6 weeks apart for people.
Okay.
And then they're coming in maybe once a year for like, a touch-up, maintenance. Because because you have a laser doesn't mean that you don't stop making redness in the future. And how fast that redness comes back is so person-dependent.
Yeah.
Like I could laser myself quarterly and be satisfied because I just make red spots so quickly.
Yeah. If people are listening, they're like, what is that? What are they talking about? What is it?
Like the laser specifically?
Yeah.
So basically an XLV or a pulse dye laser, they're both lasers that have a very specific wavelength of light that target hemoglobin or red in the skin. So lasers are really good at doing like one thing well. And so XLV and V-beam are really good at hitting red in the skin. And so essentially they are causing trauma, but controlled trauma to the red spots in your skin. They're causing damage, and then your white blood cells and the rest of your body can come in and clean up that damage and move it out of the way. So we're controlled destruction of the target tissue is really what we're trying to do with a laser.
Right. It's just like wild when you see the videos. It's like the blood vessel just boop. It's like boop. It's like disappears.
With that, you're essentially putting the blood vessel into like spasm and it's shutting down.
Okay.
It's interesting because that makes for a great little video where you see it go away, but actually usually it will like rebound and come back like a minute later.
Okay.
And then, but it's been damaged, and then your body can come in and clear it. But that is so satisfying to watch.
Yeah.
I want to ask you about Demodex, which you mentioned, and how many of us are likely to have it on our face right now?
Like 100% of us.
Wow. Okay, so what is it?
So Demodex is a microscopic mite that lives on our face, and more specifically in our pores. There's a couple different types of Demodex that are common on humans. So Demodex follicularum and Demodex brevis. And essentially, they live there. They're considered part of like the normal microbiome that lives on our skin. They love oil. They eat sebum. So if you're someone who's more oily, you're probably more likely to have Demodex on your face. And again, like people who have rosacea are usually having an atypical reaction to the Demodex. And it's not a fully understood relationship, but when we look at people who have rosacea, they are more likely to have an overgrowth of Demodex there. Yeah.
Okay.
So fun to think about. I know. But it's on everyone, and it's not contagious. Like, it's not like if you like make out with someone who has rosacea, like you then will
it's
have
not like lice or something.
Exactly. That's a good, yes.
I think, I think that this topic, one thing I just want to get across is like, people can feel like they might be dirty or it's like a hygiene issue.
Totally.
So what is there to know about, makeup brushes and pillowcases? Like what's the real on that?
It's really not a hygiene issue at all. Like both acne and rosacea, people are often stigmatized for having bad hygiene. But there's a reason that like acne doesn't happen until you're a teenager, for example. It's not because you suddenly developed bad hygiene. It's because you're going through puberty and your hormones are changing. And with rosacea too, you don't have to worry that like Demodex is because you're not cleansing properly. I just tell my patients, like, you're just a really generous host. And there's something about your composition of sebum and your skin characteristics that make Demodex want to stick around or more resistant to cleansing and things like that. But even if you wash your face, like, you're not washing the Demodex off, which is why when we're giving treatments for rosacea and things like that, they're actually things that kill the Demodex to reduce that population or that burden that's on someone's skin causing a problem.
Yeah. Okay, this is going to sound like a really dumb question, but since we know that they like oil, if you're using some of these like oil bombs that have almost like foodie ingredients in it, like it smells kind of like chocolate or vanilla, and like, is this yummy stuff? Could this make the situation worse?
There is some
no?
speculation that topical oils, both like scalp oils and face oils, may worsen certain oil and scalp related conditions like rosacea. Dandruff or seborrheic dermatitis has also been tied to like coconut oil and using that on the scalp. So it's possible. I don't know of any scientific literature that's like specifically exploring that, but I think in theory, yes. And if you're someone who has brought oils into your routine and feels like, my skin's like more reactive, or I'm starting to get these little pustules and things like that, you might be you might have low grade rosacea that then you're triggering or fueling. But we can't say for certain because human sebum is its own unique dish.
Right. So does it itch? Like, how do you know when you have face mites?
Sometimes it itches. So there's a few different things. It can be itchy for some people. So some people will not have rosacea. They'll have something called Demodex folliculitis, which is usually more like on like the lower part of the face. It's a bunch of like tiny little bumps, but very much exists on a spectrum with acne and rosacea. I don't expect someone to independently, not having dermatological training, be able to diagnose that in themselves. But it can be itchy. The real way we do it in clinic is we would have someone like apply tape on their face overnight, pull the tape off, look at it under the microscope, and you can see like an overgrowth of Demodex. So I don't expect people to be doing that. But you can also usually what we do is we just give someone an anti-Demodex topical and they use it. And if their skin gets better, it's like diagnostic in that way.
And that's the ivermectin, which wasn't that like a COVID thing?
Joe Rogan. It's giving Joe Rogan.
There was actually that was a problem actually getting ivermectin ordered for my rosacea patients and my patients who have scabies, because we give it orally for people who have a scabies mite infection during COVID because it was on the run. Yeah.
Wow. So scabies is still in the world? I thought that was like a pirate ship situation.
I wish. No, it's definitely still in the world. College, just go to college, sleep on someone's couch for a day. Yeah.
Okay, what is scabies?
Scabies is another mite that lives on the skin as well, but it's highly contagious. We often see outbreaks of it in like nursing homes and in prisons. But it lives on the skin. It causes extreme amounts of itch. So if I have like an older itchy patient in clinic, like one of the first things I'm doing is checking them for scabies. But it's very unfortunate and it's rough.
Okay.
I think I'm speaking for everyone saying, I wish I never knew. Like, I could have lived without knowing what Demodex was.
I mean, just look at a picture and then you'll really wish you never knew. It looks like
I don't want to see that under the microscope.
No.
Yeah, no,
Some
thank
people
you.
say they're cute, but...
Okay. So moving on, we want to talk about perioral dermatitis.
Sure.
And maybe you can just explain what that is.
Sure.
Yeah.
You guys are kind of picking things that all exist on a spectrum with one another, which is nice because when you have red bumps on the face, it can be like, well, what is going on here? So perioral dermatitis, if you like break down the word, like peri means around, oral, the mouth, and then dermatitis, inflammation of the skin. So inflammation of the skin around the mouth is kind of how you'd break it down. Sometimes we also call it periorificial dermatitis because it can be around the other orifices of the face, like around the nostrils or around the eyes. But it is essentially something I describe to my patients as like if eczema and rosacea had a really frustrating baby, it's that. So for some people, it can look just like little acne bumps. For some people, it will look more like eczema, so dry, scaly patches, but often like right under the corners of the mouth, right around the rim of the nose, and then the telltale is like when it's up around the eyes.
Mm.
But it can be triggered by so many different things, and that's the other issue is like, especially as women, we put so many different things on our face. We come in contact with so many different things. It's also more prevalent in women in their like 20 to 40s age range, but also kids get it who don't do anything to their face really. So we don't fully understand, again, why people get these things, but it's endlessly frustrating for patients and for dermatologists because it's quite stubborn. Yeah.
And so what do you recommend to people who you've told them they have perioral dermatitis?
Yes. So usually, if they have new skin products that they've incorporated, we have them take that out. There's a thought that it could be triggered by fluoride in toothpaste as well as sodium lauryl sulfate. So we usually have them go to a fluoride-free shampoo, or not shampoo, that would be rough, toothpaste, but temporarily. People are like, oh my God, I can't use fluoride forever. No, just temporarily. There's also some triggers associated with like mint and cinnamon and vanilla flavoring. So if they're like a gum chewer or they use a lot of mouthwashes or things like that, we really just kind of like look at their oral hygiene in general and just sort of like take the unnecessary things out temporarily.
Right.
And then often we will go down to like the most bare bones routine. So you might be noticing a trend here with diagnosing and treating skin conditions is like take out everything that's not an essential and then build the skin routine back as needed. But oftentimes we'll do something called zero therapy if possible, where I don't have them put anything on their skin for like a week, and they hate me because that's really uncomfortable in some ways, but it can really help kind of just determine if there's a trigger there. And then I'll usually prescribe a topical anti-inflammatory or even rosacea triple cream can be very good for perioral dermatitis and just see how things go from there.
Right, right.
And that's only by prescription, the triple cream.
Only by prescription. I know.
All
sorry.
Right.
But it's worth it. I think it's worth it to try. Like the number of people I've prescribed rosacea triple cream to who have then come back to me and like been like, Dr. Ellis, you're a miracle worker. You've changed my life. I'm like, I so appreciate that, but like literally just needed to be on the right medication.
Yeah.
It can make a big difference for people.
Well, that's what apostrophe is for as well.
Yeah. Curology and all
order
of that.
it all up.
Yeah. But I know that we could do a whole show about acne, and maybe we'll have you back to do that at one point. But I wanted to ask you, just because we're talking about this glossary of terms, and I hear a lot of people talking about microdosing in the sense of microdosing Accutane.
I was like, I did not think you were going to say Accutane.
Yes. So they're basically what this is they're taking Accutane for a longer period, lower dose, so their acne doesn't come back. So what are your thoughts on that?
So I think that can be beneficial for some people. With Accutane, if taken like the standard way, which is usually a weight-based dosing, and you're taking it for like 5 to 8 months for most people, like 50% or more of people are never going to have acne again after they do acne or Accutane the right way. That being said, there are some people who have residual adult acne and oftentimes rosacea as well, where being on this very low dose Accutane, maybe 3 times a week, 10 to 20 milligrams, really can help keep their acne at bay. It's tricky because it's not been studied in that way. So from a safety perspective, we don't have all the data about what long-term Accutane dosing does. We know in the short term it can have some side effects, but those are generally transient side effects that go away when you're done with taking the medication. But cumulatively over years and years and years and years, we don't have as much information on that. But it does work very, very, very well.
Yeah. So do you recommend it then?
Microdosing?
Yeah, in your practice?
There are I can think of like a handful of patients where it works really well for them. But I think first I would try to treat it in sort of the more standardized way. The other thing is Accutane is a highly controlled medication in the United States. There's a lot of jumping through hoops that happens with insurance, that happens with monitoring, that happens with having to be enrolled in this national program called iPledge when you're on this. And so if someone is taking it in a non-standard way, it usually necessitates them coming into the office once a month while they're on that medication. And a lot of patients don't really want to be in your dermatology office paying a copay or paying out of pocket every month. But that is really the law when it comes to prescribing this medication.
Okay.
Yeah.
Okay.
But I do think for some patients, it is the right move. And I've definitely done it for people.
You have. Okay. Okay. Good to know.
Yeah.
All right. Continuing on with our
glossary.
Grand glossary that we're putting together
I'm
here.
worried you're going to give me one and I'm going to be like, what?
Oh, I don't think so.
There's no way. There's no way.
Seborrheic dermatitis.
Yes.
So, some people know about this as it relates to the scalp, but this can happen on the face apparently as well.
For sure.
What is this and how do you know when something's up and, maybe this is it and you need to get diagnosed by a derm?
Right. So seborrheic dermatitis is in the family of dandruff. I would kind of describe it to someone as extreme dandruff, and it can happen on the scalp. So especially if someone has a lot of flaking or greasy scale, but also has some redness to their scalp. That's seborrheic dermatitis typically, but it can exist on the more oily areas of the face because this is caused by a different overgrowth of an organism on the face called malassezia. That's a yeast, and that can also cause inflammation. And that's usually where we're seeing redness, but also if you look closely, like some type of greasy or flaky scale, and that's usually like between the brows, in the nasolabial folds here, so around the nose, and sometimes in the beard area. Like for men, I see a lot of people who have seborrheic dermatitis throughout the beard because it's just another kind of oily hair-bearing area for people. But I would say it's sort of like redness plus a greasier scale, and it can be very frustrating for people. It's more common in men, but I do see it in women
Is it
as well.
itchy or no?
Typically not really. Some people will report itchiness, but I would say more often a patient is just coming to me because they have this very annoying facial rash that doesn't really do anything, but the appearance is bothersome to them.
Okay.
Yeah.
Interesting.
Yeah. And I'll also look at their scalp. So if someone has these facial complaints, part of my diagnosis is looking at their scalp and seeing if they have scalp involvement, because if they do, that's more consistent with a seborrheic dermatitis diagnosis on the face.
Okay. When I had my crazy flare-ups, which our listeners will know about a couple of years ago, which was like flaming red in the center of my face and extremely itchy, and it took like a week to go away. I talked to you about this. One derm had suggested it was seborrheic dermatitis and put me on the protocol for that. So it was like antifungal shampoo and conditioner. I don't actually think that's what I had, but anyways, whatever. But what it was interesting when you and I talked on that Zoom call is that we started talking, because I was like, why are they giving me shampoo and conditioner when I have no symptoms on my scalp? This is what's going on my face.
Right.
And, you know, then we started talking about shampoo and conditioner and how a lot of people don't realize that what's going on your face might be related to what you're putting on your scalp for shampoo and conditioner, in the same way that I'd been given this antifungal shampoo.
Right.
So then we talked about like, what are some of the common triggers that maybe people should look for on a label that could be screwing up their face?
Yes. So I would say fragrance is probably like the number one thing. There's also things called formaldehyde releasers. So those can be common in shampoos. And if you go and look, there's like a whole list of them. But like things that say like quaternium or DMDM hydantoin, these are things that are not dangerous for most people. Like there's no problem having them in your shampoo if you're not allergic to them. The problem is like a subset of the population is allergic to them. And it is interesting how a lot of people will not get dermatitis or inflammation on their scalp when they're using these, even though they're allergic, but they will get it on their face. But it typically tends to be on like the periphery of the face, the neck, things like that.
This is our last question for you. And thank you for this dermatology glossary. You're a wealth of information.
No problem.
As a millennial dermatologist,
sounds bad now.
How do you think your approach might differ from someone who's like a boomer derm or a Gen X derm, you know?
I think there's a bit more casualness and also collaborativeness in my generation of physicians, where I think medicine used to be a little bit more patriarchal, where it's just like very dogmatic. The doctor tells you what to do and you say, yes, sir, thank you. And you move on and you go home and you don't ask questions. And I think I try to really work with my patients collaboratively. And this is not to say that someone in the boomer generation couldn't do that or a Gen X generation, but I think as a millennial dermatologist, I am really working collaboratively with my patients to come up with solutions. I also think that patients now have a bit more knowledge because of the internet and things like that. So they're coming to me with ideas and being able to tell them like, that's not quite the right way to think about this, but in a very diplomatic way is now something that has to be part of my practice as well. Right. I also don't see as many patients, so I try to have a more condensed schedule where I'm spending a little bit longer with all of my patients. And I think that, you don't make as much money doing that, but I think my patients need that from me. And so it's something that I'm willing to give them. And it makes my job feel more satisfying because I'm not just like, oh, get through the patient. It's just a mill of people coming through. But these are like people who have like very meaningful conditions and they're concerned. And I want to be more of like a doctor, but also like have a companionship role for them as well.
Right. Yeah. Well, we've spent a whole hour with you today. We cannot afford this. I'm sure of it. So
I'll send a bill through.
Yeah, exactly. It's lost in the mail. Payment's lost in the mail. But thank you so much.
Thank you so much.
It's been such a pleasure. Thank you.
Thank you so much.